Greetings. In this video, we shall discuss about shock, and I suggest that you watch the earlier videos in advance before going through this, because there are so many topics about inflammation, the metabolic response to trauma, hemostasis, fluid and electrolyte balance, which are the foundations for this chapter of shock. So if you see them, the understanding of this chapter will become more easier. Pathophysiologically, shock is defined as a failure of the circulation to meet the metabolic needs of the cell, followed by its consequences. Initially, the cellular injury is reversible, but if this hypoperfusion is prolonged, the cellular damage and the injury becomes irreversible, and cells put together form an organ, and this also leads to multiple organ dysfunction syndrome. Broadly, there are 6 types of shock, which we shall discuss in detail in the following slides. The core principles of management of the shock, the critically ill patient or an injured patient, remain the same. One should control the airway and mechanically ventilate the patient to ensure adequate oxygenation. To carry the oxygen to the cells to prevent hypoxia, one needs to control the bleeding and also resuscitate the circulation, keeping in mind that inadequate resuscitation is too bad because you will never maintain the circulation, and overzealous resuscitation is harmful because that will dislodge the clots and further cause bleeding. Ultimately, the pathophysiology in the cellular level is the same regardless of the etiology. It could be because of the shock. It also could be because of pain, hypoxia, hypercarbia, acidosis, infection, rapid changes in temperature, hypoglycemia, or emotional arousal. As we had seen in the earlier chapter, all these causes, whether shock or otherwise, will finally lead to a neuroendocrine response, which then will also cause an inflammatory response. And the goal of this response is to maintain cerebral and cardiac perfusion at the expense of other organs. These are regulated by many receptors, and ultimately the goal is salt and water retention, vasoconstriction at the periphery, and fluid shift into the intravascular space. Now, to take this same concept a step further, you will realize why is it that people require general anesthesia during surgery. This is only to prevent the neuroendocrine and the inflammatory response to pain, because there is a lot of pain, a lot of fluid shift, a lot of change of temperature, and hypoxia during an operation. It also gives you a reason why during laparoscopic surgery, every port site should be injected with anesthetic agent. This is again to prevent the same response and to dampen the DMPs which come out from there. This diagram represents what we have just talked about, either a cellular effect by DAMP or PAMP can cause a sequence of events which lead to cellular activation and decreased tissue perfusion, ultimately as caused by a reaction between the inflammatory cells and endothelium, as discussed in earlier videos. The same can be caused by direct effects by the various types of shock to lead to decreased tissue perfusion, and this will then lead on to cellular hypoxia and ischemia. There are more reactions after the cellular hypoxemia and ischemia, which, if untreated, become irreversible because there is going to be further tissue injury and release of more mediators causing a vicious cycle of cellular activation, coming down to tissue perfusion. So this is what makes the shock irreversible. Using the foundation of the previous slides, shock was earlier classified into three stages. A compensated shock, wherein the inflammatory and the neuroendocrine response try to compensate for the amount of volume loss. And all these steps were classically seen in the hypovolemic or hemorrhagic shock. The compensated shock usually occurs for loss of up to less than 15% of volume. But if there is more than 15 to 30% of loss of volume, now it moves on to the reversible phase because the shock can be reversed by resuscitation with fluids. But if there is further loss, that is more than 30 to 40% of blood loss, it needs an operative intervention for the control of bleeding and also good resuscitation in the form of airway management, ventilation, resuscitation, correction of hypoxia, correction of injury. And if this is not done, then the shock now becomes irreversible. Going into the neuroendocrine response, the afferent pathway senses pain, hypoxia, hypercarbia by various receptors. Acidosis and infection are sensed because of the TLRs and the PRRs and the pentaxtrins. Any change in temperature or emotional arousal or hypoglycemia, which is caused because of hypoxia and loss of the oxidative respiration, is also sensed. Now, the efferent responses to the neuroendocrine response are both cardiac and hormonal. There is an increase of ACTH, catecholamines, aldosterone, and renin-angiotensin in the system. And when these get secreted, they tend to increase the preload, the ventricular contraction, and the afterload. At the same time, there is increased contractility, increased rate of the heart, and this increases the oxygen demand of the myocardium. And if this myocardial oxygen demand is not met, there is going to be cardiac dysfunction. There is a redistribution of blood flow with a decreased blood flow to the skin, the kidney, and the bowel. And this also tells you why there is going to be an acute kidney injury during shock, and also why there is a decreased urine output. At the level of the microvascular circulation, there could be an injury caused primarily because of the shock, and the sodium potassium pump will not work when there is no oxygen and also there is no glucose. When this occurs, there is a cell swelling, and this cell swelling of the endothelial cells and the inflammasomes and the general tissues of the parenchyma will lead to a poor peripheral circulation, activation of the inflammasomes, a procoagulant effect, and finally there is a poor perfusion, which compounds the primary problem of shock. This leads to the metabolic effects of hypoxia, poor oxidative respiration, and acidosis. And the cellular response of increased gene production and protein production gets stimulated. The immune and inflammatory response are in concert with all of these. And as we had seen earlier, the DAMPs and PAMPs act on the TLRs, also stimulate the pentaxtrins, which causes release of the cytokines in the complement pathway. The inflammasomes get activated, and now there is going to be also a cell and endothelial response, which starts pushing inflammatory cells away from the intravascular tree into the tissues, now causing further damage. Hypovolemic or hemorrhagic shock is one of the most commonest causes of shock in surgery and trauma. The classical responses that we talked about are seen in hypovolemic shock, and usually it goes in three phases depending upon the amount of blood loss. If there is less than 15% of blood volume loss, which is around 750 ml, in a 70 kg individual, there are very few symptoms seen and the shock is well compensated. Up to 30% of blood loss, that is around 1.5 liters, the patient may present with signs of tachycardia and tachypnea. But when there is more than 30% loss of blood volume, there is hypotension and marked tachycardia, which is more than 120 beats per minute. And when there is a loss of more than 40% of circulatory volume, more than 2 liters, it is life-threatening and usually requires operative control of the bleeding. There are differences in the presentation of the young, who can compensate very well, and the elderly, who can poorly compensate. And one should also remember that during shock and the initial investigations, one should concentrate on the ABG, because that will show you the lactate, whether it is rising, and the reason has been explained in earlier videos, and also the base deficit, which almost go hand in hand. We shall discuss more about the lactate and base deficit in the coming slides. The base deficit could be mild, moderate, or severe, and one should keep in mind that in hypovolemic shock, there are major causes of blood loss. It is called as blood on the floor and four more, which means either the patient could have lost the blood in the field, or the mnemonic crap, which means the chest cavity or the pleural space. Each pleural space could take up almost about 2 liters of blood. The retroperitoneum, which could easily take up 5 liters of blood. The peritoneal cavity or the abdominal cavity, which can take up quite a bit of blood. The pelvis and the long bones, which can easily take around 2 liters of blood. The treatment for hypovolemic and hemorrhagic shock has been discussed in the chapters of damage control, resuscitation, and hemostasis. So please look at those videos. And in brief, you will need to control the airway, the breathing, and resuscitate the circulation, keeping in mind that you will want to keep the blood pressure at around 80 to 90, and you will start with the damage control resuscitation. And I shall go and discuss this further in the coming slides. One should bear in mind that if the trauma patient has a systolic BP of less than 110, it's not a very good sign. Second of all, a trauma patient with major abdominal injuries requiring emergency laparotomy has more chance of dying in the ED if the length of time in the ER is increased. That means to say, for every 3 minutes that your trauma patient stays in the ER, you increase 1% chance of death, and this increase is seen up to 90 minutes. Now, the initial resuscitation, as we discussed, wants to keep the BP around 90 millimeters of mercury, because if it is overly aggressive, one would dislodge blood clots, and if the resuscitation is less than perfect, there is actually further cellular hypoxia and lesser tissue perfusion. When there is vigorous resuscitation initially with the crystalloids, remember that this crystalloid is trying to resuscitate not the intravascular volume only, it's also trying to pump that volume into the space from which it was taken off. So the fluid shift reverses to some degree. But also, over-aggressive resuscitation will cause a dilutional coagulopathy, compartment syndrome, pulmonary edema and acute lung injury, cerebral edema, and an immune dysfunction. So all this should be kept in mind during the resuscitation. When the patient comes in and the primary, secondary survey and the resuscitation begin, one would want to note the ABG values to check for tissue hypoperfusion. And if there is evidence of tissue hypoperfusion and the patient is unstable hemodynamically, one would try to defer the diagnostic studies. one would want to start the volume infusion, and during the resuscitation phase, one would want to start two large bore IB lines, usually a 14 or 16 gauge. And depending upon the site of injury, you would want to start a central line very close by to the heart so that your resuscitation will become better than a peripheral line. One should remember not to start the IV line in the injured limb. And if there is an injured side of the chest, put the central line in the injured side. The reason is, if there is an injury on the right and one inserts a central line on the left, causing an iatrogenic pneumo or hemothorax, one is compounding the injury. Therefore, try to place the central line in the side of chest injury. Second of all, you should always have an access, one above and one below the diaphragm. One would want to use warm fluids to prevent hypothermia. At the same time, during transfusion, the patients are classified into three categories. The responders, who rapidly correct their shock with minimal replacement of an intravascular volume. This is because the loss of volume has stopped or it has been tamponaded. This can happen in multiple fractures, neurogenic shock, and obstructive shock. The transient responders are those who initially improve with the resuscitative efforts, but they subsequently deteriorate. And this is usually seen in intracavitary bleeding that requires surgical control. So one should keep a note of this. The non-responders are those in whom persistent manifestations of shock present despite vigorous resuscitative efforts, and this is usually caused because of a high volume bleeding from a major blood vessel or severe injuries to solid organs that would require immediate operative control. Now, those non-responders and transient responders should be taken to the operative room for control. Whereas if there is a responder, then one can go on for a rapid diagnostic evaluation to now classify as to which kind of shock the patient is having. Is it purely a hemorrhagic shock, which requires operative treatment, either a cardiogenic or traumatic shock, which requires supportive care, a neurogenic shock, septic shock, or an obstructive shock, which would require either decompression of the pericardium or an intercostal chest drainage tube or a thoracotomy. Now one should keep in mind the type and the volume of the fluid that one uses for resuscitation. The ideal crystalloid that is given is Ringer's lactate because it almost imitates the electrolytes in the plasma. Fresh frozen plasma corrects the coagulopathy and results in higher survival, and it is a very good resuscitative fluid to use. In the army, they use a lyophilized plasma, that is a freeze-dried plasma. The plasma is taken to a freezing process. It's then maintained under vacuum so that the water can come out. And this process is repeated so that this plasma becomes almost a powder form, and it can be stored up to 5 years in room temperature. Before utilization, it is usually reconstituted with around 200 to 250 ml of fluid. Traumatic shock is the same as hemorrhagic or hypovolemic shock, in addition to which the multiple factors or multiple trauma leads to PAMP, DMP, and traumatic shock could also include, in addition to hypovolemia, neurogenic shock, obstructive shock, at times septic shock, and cardiogenic shock. In addition to the coagulopathy of trauma, when all these are superadded, it is very easy for the patient to go into MODS, and these patients also develop ARDS very commonly. Septic shock is basically a type of vasodilatory shock in which a patient, when he gets septic shock, doesn't go into a phase of compensation and reversibility. He is directly thrown into an irreversible shock because of the sepsis, the activation of the inflammatory pathways, a rapid dysfunction of the endothelium and the vasculature, secondary to these mediators and cells, and these usually fail to respond to the vasopressors. Although in these patients the plasma catecholamine levels are elevated and even the renin-angiotensin system is activated. At the cellular level, due to sepsis there is hypoxia, lactic acidosis, carbon monoxide, and this ensures that the patient goes into an irreversible shock and the vicious cycle gets activated. Thus, septic shock is as though one has been pushed into the final common pathway. The fluid resuscitation is very essential because of the mismatch between the vascular tree and the intravascular volume. So one needs to give at least about 30 ml per kilogram in the first 4 to 6 hours. In addition to which, source control, debridement, antibiotics, vasopressors. Because these people are more prone to develop ARDS, one would go with a higher PEEP and a tidal volume of 6 ml per kg or 6 to 8 ml per kg as an ARDS protocol. Hydrocortisone and fluorocortisone, which are mineral and glucocorticoids, have been tried in septic shock. And many other immunomodulations have been tried, like anticytokines and anti-endotoxins, immune enhancers and antioxidants, all of which have shown to have very poor effects in septic shock. Obstructive shock is a type of shock in which there is a mechanical obstruction to the venous return. This can be seen in tension pneumothorax, hemothorax, pulmonary embolism, or pericardial tamponade, cardiac contusion. Actually, cardiac contusion with a cardiac injury and pericardial tamponade to be precise. All of these would require decompression, either in the form of an intercostal chest tube or thoracotomy if required with control of the bleeding, which means that the patient is also having hemorrhagic shock in addition, pericardiocentesis, and a diagnostic pericardial window for drainage of the pericardium. One should remember that when one deals with a septic shock or an obstructive shock, it's not good to keep the eyes closed and think, this is exactly what I'm dealing with. Try to look for other causes of shock also, because in the trauma patient, the shock is multifactorial. Neurogenic shock is a type of vasodilatory shock. It results because of a loss of vasomotor tone to the peripheral capillary beds. It's usually caused because of spinal cord injuries, and when there is a spinal cord injury, there is going to be shock with a vascular compromise to the spinal cord, which leads to a loss of autoregulation, vasospasm, and thrombosis. Furthermore, there is going to be a loss of cellular membrane integrity because of this shock, and also an impaired energy metabolism. This leads to the accumulation of neurotransmitters and release of free radicals. Now, all these will worsen the acute spinal cord injury because there is a further reduction of blood flow to the spinal cord. When the patients usually present, they have decreased blood pressures, bradycardia, warm extremities, and on examination, if the patient is conscious, there are sensory and motor deficits. Usually they are associated with spinal fractures. Now, one should remember that when you see a case of neurogenic shock in a trauma patient, one should exclude other causes of shock, because you never know, in a polytrauma patient there could be blood loss or head injury or obstructive shock, and if one keeps a tunnel vision on neurogenic shock, he might miss the bus. If there is pure neurogenic shock, most of these patients will respond to a good volume resuscitation, in addition to which some might require vasoconstrictors. And usually these vasoconstrictors are required for the first 24 to 48 hours. Either dopamine or phenylephrine may be used. And the duration of the need of vasopressor support correlates with the overall prognosis of the improvement of the function. This rapid restoration of the blood pressure with resuscitation and with vasopressors has a beneficial effect on the spinal cord because it prevents progressive ischemia of the cord and minimizes secondary injury to the spinal cord. So one should proceed to resuscitate the normal hemodynamics before trying to do any operative intervention on the spinal cord and try to stabilize the vertebral fracture. One should also bear in mind that those who are hypotensive from a spinal cord injury require ICU care and should be followed for evidence of cardiac or respiratory dysfunction. Cardiogenic shock is caused because of a pump failure in the presence of adequate intravascular volume. Usually in the cases of trauma patients, in penetrating injury, one would see a cardiogenic shock. Otherwise, for a blunt cardiac injury, most of the cardiogenic shocks are self-limiting. But one should always look for other causes of shock in the trauma patient, although one suspects cardiogenic shock to be a part and parcel of the issue. Most of the time, the cardiogenic shock is caused by medical conditions, so I wouldn't want to discuss any further because I don't have much of experience in this field of myocardial infarction, etc. So I wouldn't want to give you information about something which I am poorly informed and not having much experience about. Further to the definition of shock with cellular hypoxia and derangement of metabolism. As we discussed earlier, the tissues demand around 200 milliliters of oxygen per minute. Now, if the tissues get hypoxic, there will be anaerobic metabolism taking place in those tissues. And when the circulation and the oxygen delivery are restored, there is going to be a difference between the normal demand of the tissues and the actual consumption of oxygen of those tissues. Now, this difference between the oxygen consumption and the oxygen requirement, it is what is defined as oxygen debt. And one sees that the serum lactate and the base deficit correlate with the oxygen debt. Now, one would always wonder to know what is the depth and the duration and the degree to which the shock has affected the patient. So one would need certain parameters to measure, and when these parameters have been deranged, you know that the degree of shock was very bad. And when these parameters are normalized, you know that we have reached the end point of resuscitating the patient. One also knows that the global or systemic parameters include the heart rate, the blood pressure, skin temperature, urine output, the pulmonary artery wedge pressure, the oxygen delivery and consumption, and lactate and base deficit. Most clinicians would agree that although the patient may be hemodynamically stable, there is cellular hypoxia occurring at the level of the tissues because a normal heart rate or a blood pressure in compensated shock doesn't reflect anything at the tissue level. So the global parameters or the global endpoint of resuscitation may not nearly reflect what is happening at the tissue level. So there could be shock, although the patient hemodynamically or globally doesn't present as shock. We have seen earlier as to how lactate is generated, and we realize that the lactate is taken up by the liver. Up to 50% of the lactate is taken by the liver and 30% is taken up by the kidneys. But during the phase of shock, the kidneys get hypoperfused. So this lactate, which is present in the blood, will reflect upon the arterial hypoxia. Studies have shown that those patients who are unable to reverse their lactic acidosis in the first 12 hours develop infections thrice as more as those who normalize their levels. In addition, those who developed infections have mortality fourfold higher than the usual population. The base deficit is defined as the amount of base in millimoles that is required to increase or normalize the pH of acidotic blood to 7.4, with the blood being fully saturated with oxygen at the right temperature, which is physiological, and a partial pressure of CO2 at 40. Studies have shown that a base deficit of 0 correlates with a mortality of 8%. The normal base deficit could be +2 to -2. Whereas there was a mortality of 95% at a base deficit of 26 millimoles. The right ventricular end diastolic volume index seems to accurately predict the preload for the cardiac index as opposed to pulmonary artery wedge pressures. And studies have shown that more than 50% of trauma patients with persistent splanchnic ischemia were reversed by increasing the right ventricular end diastolic volume. The tissue parameters that we shall discuss are gastric tonometry, end tidal CO2 levels, and near infrared spectrometry. Gastric tonometry tries to assess the perfusion of the GI tract with the premise that the bicarbonate in the stomach is equal to the bicarbonate in the serum. Therefore, the CO2 levels in the gastric mucosa are sampled with a specially designed nasogastric tube. The intramucosal gastric pH is then calculated using the Henderson-Hasselbalch equation. It has been shown that those who are having a normal pH have better outcomes, whereas those who have a lower pH reflect lower perfusion of the tissues and thus have a poor outcome. The end tidal CO2 levels work on the premise of the ventilation perfusion ratio. Those who are in shock have a poor cardiac output and a poor pulmonary perfusion. Therefore, they will not be able to have a good gas exchange. Therefore, it is shown that survivors have a higher end tidal CO2 level, which means to say that there is perfusion going on. A near-infrared spectroscopy works on the same physical principle as pulse oximetry. Both of them transmit light into the tissues and absorb the light on the opposite end. The difference is that pulse oximetry remains stable. It mainly checks what's happening in the capillaries, and it mainly reflects what's happening in the hemoglobin, and the difference between oxy and deoxyhemoglobin forms two different curves, and that calculation reflects as the SpO2. The NIRS is different because it measures the tissue saturation of oxygen, and how it does so is that the light it transmits is absorbed by melanin, keratonin, bilirubin, and hemoglobin, myoglobin, and cytochrome AA3. Now these molecules, especially hemoglobin, myoglobin, and cytochrome AA3, will change their spectra depending on when they are oxygenated and deoxygenated. Cytochrome AA3 levels will start reducing when the tissue oxygen demands start increasing. It is one of the constituents in the electron transport chain. Therefore, the StO2 measurements will actually reflect the balance between the oxygen supply and the oxygen consumption, thus also reflecting the oxidative metabolism in the muscle. Various studies have shown that skeletal muscle and gastric StO2 measurements correlate pretty well in shock, and it also correlates with the delivery of oxygen. When these are compared to the liver StO2, they were less correlated, thus showing that the liver has some kind of a protective circulation during shock. When one compares subcutaneous and skeletal muscle StO2 to the invasive delivery of oxygen, there is a difference. Thus, skeletal muscle StO2 correlates well to show how exactly the perfusion is going and how exactly the metabolism is going. Studies done by Tyler have shown that NIRS is 78% sensitive and 39% specific to predict MODS. It is also 91% sensitive and 31% specific to predict death. Although there are some limitations, the StO2 measurement seems to be a useful parameter in determining the status of the perfusion and also predicting morbidity and mortality. So additional studies will actually open up the potential benefits of NIRS. The cellular parameters of the endpoint of resuscitation are measurements of the tissue pH, tissue oxygen, and the tissue CO2 concentration. Tissue probes with optical sensors, also called as optodes, are used to measure these parameters in the subcutaneous tissues, the muscles, and the bladder. They may also be inserted percutaneously to monitor the tissue perfusion. It has been shown that those who have a lower pH, a lower oxygen concentration, and higher CO2 concentration have poorer outcomes than the patients who have almost near normal results. Thanks for watching. Like, comment, subscribe, email me.